طيب، بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيدنا وحبيبنا ونبينا محمد وعلى آله وصحبه وسلم. بسم الله نبدأ. Our topic for today is systemic mammographic approach to analyze the architectural distortions. So starting by the definition of the architectural distortion is defined by the imaging reporting and data system, or the ACR, as a descriptive term in breast imaging, all imaging, mammography, ultrasound, and MRI, when the normal architecture of the breast parenchyma is being distorted. That means it's being tethered, it's being angulated, it's being indented, okay, without a defined mass lesion visible. You see? Then we call it architectural distortion. We complete already the analysis of the first major abnormality in mammographic lexicons, the masses, asymmetries, and calcifications, and the fourth major mammographic abnormality in the lexicons is the architectural distortion. We are going to talk about it today. Okay. So architectural distortion is the third most common mammographic appearance of non-palpable breast cancer. It represents 6% of abnormality detected on screening mammography. Although its prevalence is small compared to calcifications and masses, the architectural distortion is more difficult to diagnose because sometimes it's very subtle and variable in presentation, as in this case. If you look, the parenchyma, all the parenchyma is complex. This area representing subtle architectural distortion. And architectural distortions might not have an apparent correlated ultrasound features that make it more difficult and more challenging, both in diagnosis as well as for biopsy. Okay, so architectural distortion is a common finding in retrospective assessment of the false negative mammography and may represent the earliest manifestation of a breast cancer. Specifically, architectural distortion account up to 45% of breast cancer cases overlooked or misinterpreted on screening mammography. And in a study of cases of screening interval breast cancers, it has been found that architectural distortion is the most common missed abnormality in false negative cases. So when they brought the misinterpreted or false negative mammography, they found the most common abnormality being missing is architectural distortion. And in some studies, they suggest that early detection of architectural distortion is more important than early detection of calcification. Why? They found it is more significant, is giving more significant improvement in prognosis of breast cancer than the early detections of calcifications. Architectural distortion is mammographic finding associated with a high positive predictive value for malignancy. In some studies mention 60, and some studies mention up to 74.5% on diagnostic mammography. So in most cases, architectural distortion is a suspicious findings and should be coded as BIRAT 4 at least. Okay, what is the pathology of architectural distortion? As described in the BIRAT Atlas, there are several features that can be considered as part of architectural distortion, which include contour abnormality, trabecular thickening, and trabecular disorganization. Okay, so what are the possible appearances of architectural distortions? See, it can appear as radiating lines, alterations of normal contour, or both. Okay, that can give radiating lines, the radiating lines seen as the thin lines or speculations radiating from a point. And the contour can be seen as focal retraction, distortion, or straightening of the edge of the parenchyma. Can be seen as focal retraction, buckling of the connective tissue lines anywhere within the breast, not necessarily at the contour or the interface of the fat glandular interfaces, contour of the fat glandular interfaces, or can be blurring of normal tissue planes as the fat glandular junctions, can represent as a straightening or thickening of the Cooper ligaments, and can be seen as compression from an adjacent mass. Okay, what you can see here, which type of the above mentioned architectural distortion here, you can see
lines radiating from a point.
Excellent. This is the commonest or the typical architectural distortion manifested by thin radiating lines with the primary radiolucence point. Okay, the lines pointing to that area or central regions. This is as illustrated here. This is a typical and commonest type of architectural distortion. And this is not always necessarily, if you look here, you can see the line radiating throughout the central point in all directions. But this is not always the case. As you can see in this lesion, the lines are radiating toward the anterior aspect only, but are very long lines, see, projecting into the parenchyma. It can be asymmetric, not always necessarily to see these lines in all directions. You can see it in one direction, you can see it in some and the others, and you can sometimes the image itself not include the whole area of distortion. You have seen part of which, but anywhere, if you can see this, you see subtle distortion, you have to take it seriously, okay? And you have to clarify it and furtherly evaluate it to make sure there is no underlying suspicious architectural distortion. Features can represent malignant, breast malignancy. And in this case, it was the biopsy was infiltrating ductal carcinoma or these lesions. Okay. Speculated mass versus architectural distortions. Okay. Any volunteer who's gonna take this case? Number one, is it an speculated mass or an architectural distortion? Huh?
Speculated mass.
Who is talking?
Hint.
You said what? Speculated mass or architectural distortion? I did not hear you.
I said mass, speculated mass.
Okay, you said the speculated mass, huh? What about two? Any volunteer? Medina, where are you? Abir.
Yes, it is architectural distortion.
Which
line,
one? Which
number,
one?
Number two.
Number two, architectural distortion. It's okay. Number three.
I think one is speculated mass. Number three.
Abir, you are talking? Who said
Yes.
speculated mass?
Number Abir is talking. Number three is speculated mass.
Okay. Suhair, what do you think about the three cases?
Speculated mass.
Which one?
Number three, speculated mass. 1 and 2, architectural distortion.
Okay. Any other suggestion?
Also, I think 1 and 2, architectural distortion, while 3 is speculated mass.
Okay.
Uh-oh.
And 4? Do you
Four,
want to
I
change
think
your mind?
I changed my
Mass.
mind. 4 is the only mass, yes, and all the others is distortion.
Excellent. Excellent. Well done. 4 is only the speculated mass, while the others are architectural distortion. I will show you why 3 is just architectural distortion. This is the same case from different angles. Okay?
Yes, 3 here is the compression. Yes, we need compression. So compression.
No, this is different angles. Both are compression. Both are compression, but one CC view, the other MLO. And
Okay.
since you remember the definition of the mass,
Yes.
it has a consistent shape in different views. And here there is no. You see, this is an architectural distortion. So it is important to differentiate between the mass, okay, speculated mass and architectural distortion. And if you look here, the central point is lucent. The periphery are more dense than the center, Yahind. Yes? Do you agree?
Yes,
So,
yes, I agree.
so this is again is the definition of a mass. Okay. What is the difference between, or how we could differentiate? Hind, don't comment. I know you know this area. Or the
Okay,
others.
okay.
What is the difference between the architectural distortion and submission artifacts? Sometimes you put in our reports, this is area, it is likely represent submission artifacts. No, this area is likely representing architectural distortion. Right, how we could be more confident to tell this is architectural distortions? Yes, sometimes there are challenging cases. It's difficult to say exactly what is this and what is that. But most of the time we have to tell. If we have a good high resolution image, we have to differentiate between architectural distortion and submission, or at least we have to know the principles. If somebody asks you or ask me why this is architectural distortion, why not submission artifact, I have to explain for him based on this, okay, criteria. I said this is summation artifacts, or based on that I said this is architectural distortion. So from these illustrations, from the illustration you have seen in front of you, tell me the difference between architectural distortions and the summation. What is it? What A, B, and C represent? Which one is summation artifact and which one is architectural distortion? No volunteer? Abir, Suhair, Medina, Where is Magdalene today? I think Sarah Abnaouf is here. Where is Sarah? Other Sarahs. Sarah Usman, Sarah Isam, and Sarah Al-Mak. All of these are not available. Dr. Iman. Who said I think?
Me, Abir. A is architectural distortion. B and C are summation artifacts.
Excellent, well done. Why you said like that?
In A, it appears like there is radiating lines from a central lucency, as in the definition of one of the types of architectural distortion.
Excellent, well done. Why the others is not architectural distortion?
Because the lines are not radiating from a central lucency. It seems like some of the lines come across this area.
Excellent, well done. It is written above if you concentrate. Here, you see, normal structures like fibrous band, or like a fibrous band, which is the Cooper ligaments, ducts and vessels, can create intersecting flight path that can mimic architectural distortion. However, this structure never actually radiate from a central point. And these extend through and beyond the center of questioned findings, rather than ending at the central point, are not ending like this at the central point, but passing through it, this coming aside and this also. You see, by passing and crossing this, so these are normal structures, just overlap. So this is A is architectural distortion, and the common pattern of overlapping normal structures, this is in B and C, with normal structure, not the off-center, intersecting and continuous visualization of individual line extend through the questionable points or questionable findings. Okay, so this is the difference. We'll go through some of the examples. Why this is summation artifacts? Why it is a summation artifacts? Is it a summation artifacts or architectural distortion? Don't read the comment on the right side. Just look at it. Is it architectural distortion or summation artifact? It should not appear this the comment, but I don't know. I forget to make animation. What do you think about these structures? No comment? Is it architectural distortion? Okay. Now. Architectural distortion or summation? Hint.
Summation artifact, because we see here there is a little hyperdense lesion and the lines are crossing through it. They
Yes,
are not ending. Yeah.
You are right, 100%. The central area is hyperdense rather than a lucent area, and the line passing through this questionable area. Okay, not pointing to that area. Although this is super, how we can manage, how we can make sure, how I can make sure this is just a summation artifact. What are the techniques we can use it?
Rather than the compression view.
Yes, we had done the
we
spot
can
compression.
ultrasound also. Ultrasound
or
can
we use the computer? Can we use the computer?
I don't know if there is subtraction. I'm not sure.
Yes, you are right. Subtraction. We can do subtraction. And when you do a subtraction, definitely the normal structure, it will be subtracted. It will not be stay. But you can use the computer-aided detections or subtractions type. So, okay, what about these examples? Is it summations or architectural distortion?
Architectural distortion.
Why?
There is a wide lucent area.
Yes.
And there are radiating lines from it.
Yes, there are radiating lines are not crossing that question. And usually with summation, we will see what? Usually more increased density rather than lucency.
Yes.
You see, super added structures result in additional density. Okay, this case is architectural distortions and manifested by radiating lines to a fatty center. central point or origin, or biopsy revealed invasive ductal carcinoma. Look for this area, easy be missed on mammography. Do you agree or not?
Yes.
Yes, it was invasive. It was invasive ductal carcinoma. Okay, and this is another example of architectural distortion rather than superimposed. Here, as if there is added density, but in the other view, you see, there is central point and all these radiating lines from all directions toward these central regions, you see, and it is a little bit, there are multifocal asymmetry around this distortion, and it was multifocal infiltrating a carcinoma with ductal and lobular feature. It mixed type as well as DCIS. Huh? What about this architectural distortion? Which type?
Distortion for the contour, retraction
Excellent.
of the contour.
Yeah. This is distortion of the contours, okay? Abnormal. We said in conclusion, we have two majors, either speculated lines, okay? Or radiating lines, or contour deformity. The contour deformity, it can be different appearance. In this case, you see, there is tethering and retraction and buckering. You see, if you look, there is some buckering of the normal connective tissue, key lines, causing abnormal contour. Look for the buckering and retractions. The contour, the fat glandular interface is interrupted, giving as if they have taken, you see, a tissue by a spoon from these regions. Okay, and this case? Huh?
Also, there is contour abnormality on the upper part of the breast.
In terms of appearance. How you can describe it?
It is the opposite of retraction. It's
Yes. It is. It make like.
this is,
I think radiating lines focally in one direction.
What? You said what?
Radiating lines in one direction.
Excellent. So there is radiating lines in one direction. Excellent. Okay. So it is a radiating line deformity, or hint she said contour deformity, and you said it is speculated line. So what could it be?
Combined.
Combined. Yes. Yes, this is combined. This is combined speculated lines as well as contour deformity. But yes. What about the contour deformity? That parenchyma, it was buckering of the parenchyma, retraction of the parenchyma. But here the parenchyma is
extending outside.
Angulated. Yes. Distorted and angulated. You see? It is angulated. There is some angulations and some retraction here. Retraction at one point and angulation in the other point. Okay? So, and some straightening of the edge. As if there is something rigid in this area. That was both the previous one, this one, and this one, both are my cases. Okay, a long time before, I don't remember exactly, but this one I remember that she had no ultrasound correlate, but I reported as suspicious. And I don't remember that I could find the feedback of the result. I don't remember, long time before. And what about this one?
Retraction.
Yes, contour retraction, but this is contour. This is related to the contour. Tethering and retractions, and there are thickening and distortions, and this is thickened Cooper ligaments pulling and resulting in retraction of the contour. So straightening or thickening of the Cooper ligament can result in tethering or retraction of fat glandular interface, okay, resulting in contour deformity. And in this case, it was a multifocal. This is the same as you have seen the spot magnification view for her of multifocal mixed ductal and lobular with DCIS. Okay, so how we could approach the architectural distortion? Any suggestion? Now we know what is the architectural distortion. We have seen the architectural distortion. How we could approach on mammography?
Maybe we can look at the contour, see the junction between or the interface between the subcutaneous fat and the retromedullary fat and the fibroglandular tissue from all sides.
Okay.
And then we look inside the parenchyma if we can see any radiating lines.
Okay. Then we have seen some changes. So
okay, so we request a spot compression, and we determine the area or the position of the abnormality.
Excellent.
And if the patient has previous mammograms, we compare with.
Okay.
And then we can go for further imaging, like ultrasound, for example. If it's not conclusive, then if not conclusive, then we can move for MRI.
Okay. So this is to establish that we have architectural distortion. All this, if we have seen area might suggest architectural distortion, first of all, we need to define, is it an architectural distortion or not? This is first. Then look at the area of distortion. Is there any associated calcification, associated features, associated mass, associated asymmetry, or associated calcifications? And then to localize that abnormality within the mammography, like the approach for asymmetry and for the masses. Same approach. First of all, we have to make sure that this is an abnormality. Call it architectural distortion. Confirm it is an architectural distortion. Is there any associated features, mass, asymmetry, calcifications, skin changes, whatever? Then localize the lesions. Okay, where exactly within the breast. Then, starting by the first step in our approach, we need to know how to recognize architectural distortion. Before we describe what the architectural distortion and how it appears. How does it appear? Okay, the architectural distortion, the definition of architectural distortion. when the breast surgeon, when Dr. Muawiyah came to you, Medina, okay, and asks you why you said, you report to me, this is an architectural distortion. You'll tell him, I could see here a contour deformity with angulation or with feathering or with retraction along this area of long spicules, okay, radiating to the point or radiating to this area of, there is also associated so and so and so and so. Okay, this is the architectural distortion. Then how to recognize the architectural distortion? Architectural distortion is often due to desmoplastic reaction, in which there is a focal disruption of normal breast pattern. Architectural distortion can be easily missed by inexpert reporters and will persist on a spot magnification view, but not only persist, can more conspicuous, okay, as well as the associated abnormality like masses, asymmetry, or calcification, or these. It will be, okay. Architectural distortion, as we mentioned, can be subtle. We need to target it by ultrasound, and in some cases, and the adjunct digital tomosynthesis definitely increases sensitivity, confidence, and inter-observer agreement in detections of architectural distortions and localize the abnormality. And architectural distortion can be a primary or reported as standalone abnormality, only architectural distortion as the findings, or can be associated with other findings like mass in adjacent to which, because we said when we call the area is distorted, one of the criteria is no mass lesion, no underlying mass. But the architectural distortion can be seen in a vicinity, okay, to a mass. You might have a mass, and in the surrounding parenchyma or the adjacent parenchyma, you would find an architectural distortion. Or it can be associated with asymmetry, calcifications, or other findings. So architectural distortion is suspected when we suspect it on a screening mammogram. On a screening mammogram, okay? You have a suspicious area for architectural distortion. First of all, we need to establish it. How we could establish this is an architectural distortion? How you can establish this is an architectural distortion?
By doing spot compression magnification views,
Excellent.
or looking for it on another view.
Excellent, well done, well done. So this, you call it as what? This other view. Then when we, this is, you have, okay, the patient had done the screening and she left already. And now you are reporting the screening and you are suspecting area as architectural distortion.
Looking for the previous images.
Okay, looking for previous one issue. You change your mind. You don't like to bring the patient to do these other views.
Yes, it's one of the options also. Yeah.
Okay. You will review the previous. Excellent. Well, what else? The other, when you brought the patient and you do laser images, then it will be this. You call it as which mammogram? Which setting? We said before we have two settings, yes? We said we have screening as well as as well as screening and diagnostic. When you call when we call the patient for further review, it will be
diagnostic.
still it will be diagnostic. Okay. So when options to do further imaging as diagnostic mammography to clarify and to make sure this is and still is architectural distortion. Like, review the previous mammogram if available. Excellent. These two situations. What else we can do?
We can do breast tomosynthesis as it is more sensitive.
We can do what you say?
Tomosynthesis.
Excellent. We can do tomosynthesis. What else?
Ultrasound and MRI.
Ultrasound. Okay. So if you have if you suspect architectural distortion on screening mammography, to establish, first of all, provide clinical history. Okay. The patient, they might write something significant. She might have palpable abnormality, she might have pain, she might have whatever. Any clinical abnormality is essential. Then you should evaluate it in greater details on diagnostic view by doing special views to make sure is real architectural distortion, and compare it with available previous mammogram, and then do targeted sonogram. Those who have digital tomosynthesis usually capability, usually they are doing screening 2 and 3D together. But those who have not, okay, or they are not using to do it as a routine for the screening, they can use it for in the diagnostic setting as adjunct to the diagnostic mammography to make sure if this is an architectural distortion or not. Why you are doing all these measurements? Why all these precautions before saying this is an architectural distortion?
Because we said architectural distortion is very suspicious, and we are going to categorize it as at least by RAD4.
Yes. So you're right. Any other suggestion?
We have to take a biopsy. So before taking a biopsy, we have to make sure that
Okay. So you are right. All you are right. To avoid unnecessarily biopsy and not to miss an important findings. We don't like to miss an important findings, and at the same time, not to do unnecessarily biopsy. We have to make sure this is a real abnormality and it needs to be biopsied. And you remember that we have to take it. Why it is important? They describe that, or in many studies, that architectural distortion early detections is more essential and important in the prognosis, okay, of breast cancer than early detection of calcification. We need to detect architectural distortion as early as possible to improve the prognosis of breast cancer patients. Okay, so look at this example. This is 45-year-old female. Look here, why I highlighted? She has palpable breast lump. Any patient, if you have a patient, okay, and she has a palpable, especially palpable abnormality, okay, and you could not see a specific abnormality on your imaging, or you could see subtle abnormality at the location of palpable abnormality, take it seriously. since there is palpable abnormality, you have to explain why she has a palpable abnormality. If you could not see it in these images, do the other image, okay? If you could not see it on mammography, proceed for ultrasound, and so forth. You have to explain. And even they can take a biopsy, okay, using clinical. If they can clinically palpate it, then they can take a biopsy from that palpable area, okay, blind biopsy. It doesn't, we said before, combined negative ultrasound mammography does not completely exclude breast cancer. There, I remember, yes, I think it is up to 96%. Still, there is 4 point something percent that there is a chance to have a lesion or to have to miss a lesion or something. You see, false negative up to 4.5 or 4.4%, like this. I don't remember exactly. In combination of both mammography and ultrasound. So if the patient having palpable, that is why we said we put for the analysis or to make sure there is architectural distortion along with other measurements to look for the clinical. Clinical is essential, very essential. Since the patient has palpable abnormality, we have to consider any subtle changes. Here, at the same area of palpable abnormality, there is an architectural distortion with pleomorphic calcifications. That is the same area here. On spot magnification, the architectural distortion is proven along with pleomorphic calcification, and here on ultrasound, an indistinct, okay, mass with angular margin, deeply hypocoicous posterior shadowing, more suspicious, though it's small, and biopsy revealed poorly differentiated grade 3 ductal carcinoma. Okay. This another patient, you see, screening mammography. He has extremely dense nodular breast complex parenchyma, difficult, you see, to exclude any abnormality. But look how it was subtle, architectural distortion here. Very easy to be missed. But she's luckily they could pick it up on a screening mammography, and spot magnification as diagnostic had been done for her and proven she has that, or demonstrate or make this the abnormality more clear than the spot than the standard CC view, okay, and ultrasound demonstrate a hypoechoic shadowing mass at 6 o'clock at the same locations. Biopsy revealed infiltrating ductal carcinoma. Okay, so the diagnostic evaluation of suspected architectural distortions using ultrasound is very useful in confirming, characterizing, and localizing the lesion presenting as mammographic architectural distortions. And it might also detect an associated mammographically occult mass. See? And using harmonic, it will improve the conspicuity of the lesions. However, using the compound imaging, it will elevate or eliminate the posterior acoustic shadowing, you see, of the architectural distortions, and particularly for the invasive lobular carcinoma. But this might obscure the lesions if it is the lesion, if it's too small lesions. It might not be much helpful sometimes. Okay, we'll see examples. The lack of ultrasound correlate, it does not eliminate the considerations of biopsy if distortion is present on mammography. Sometimes we can see the distortion on mammography, as I have shown to you early case, that with angular contour as well as speculation. She has no previous trauma, she has no previous surgery or interventions. So even ultrasound was normal or was not detecting any abnormality, we could not ignore it. We have to use the mammography to take stereotactic biopsy. Okay, this is what? So here, what about this image? And what demonstrate?
This is tomosynthesis image.
Excellent.
Show an area of architecture distortion as radiating lines from lucent center, and at the center.
And the square is what? What about the square?
This is artifact. What this artifact or
this
at
one.
the same area? This is the same area of architecture distortion.
Spot eye or magnification view. This is a magnification view for the same area. So this is a tomosynthesis demonstrate a subtle area of architectural distortion. As we mentioned, digital tomosynthesis or 3D imaging overcome some limitations of the traditional digital mammography. We'll see examples. If you look here, subtle area of architectural distortion and asymmetry, and here giving some angulation and distortion in the contour of fibroglandular fat interface. See, and look how tomosynthesis demonstrates an speculated mass in this area. This seen is only as asymmetry with architectural distortion, how it will be appreciated or how it's being appreciated on the tomosynthesis. Okay, so the management and digital breast tomosynthesis principles, sometimes yes, mammographic or architectural distortion seen on conventional mammography might be seen on digital tomosynthesis as just overlapping normal tissue structures. However, the tomosynthesis detecting is more sensitive in detecting the architectural distortion not seen by the 2D mammography. And as you know, the architectural distortion is challenging because sometimes it might have similar density as the surrounding parenchyma and it might contain fat. But still, as we described before, this cancer can appear like this, especially like lobular carcinoma. Okay, but also, as we have seen now, a lot of examples of invasive cancer appear as architectural distortion on the 2D due to overlapping structures. When doing a tomosynthesis, the underlying mass appear. See? So it's often changeable in appearance in different projections. Architectural distortions can be different from different appearance. We have seen example before. From different appearance can be changed in different projections and can be seen in only single view. This is also make it more challenging or make it more difficult to be appreciated. For these reasons, that is why it is a common cause of false negative screening mammogram. Not only that, sometimes also can be missed in computer-aided detections. Architectural distortions are often better seen and characterized definitely at tomosynthesis. So using adjunct tomosynthesis is useful for improving characterizations of malignant versus benign lesions regarding architectural distortions, and it can highlight more suspicious lesion as in the previous examples. The architectural distortion demonstrates underlying speculated mass, and confidently we can report it as BIRAT 5 since it is speculated. In the 2D, we report it as BIRAT 4, B or C, but after tomosynthesis, we report it BIRAT 5. So it is more useful in patient of having dense breast rather than the fatty breast. See, because overlapping tissue, it will eliminate the overlapping tissue to see what is in between these tissue lines. So the cancer detection rate for architectural distortion seen on digital breast tomosynthesis and mammographically occult has been reported to be 21.1% and 47.2%, too high. Yes, almost up to 50% of the patients. Okay, this is another example. Is a 65-year-old woman with architectural distortion detected both on screening 2D as well as on digital tomosynthesis. Look for the subtle area, very subtle area of architectural distortion seen on 2D, and look at it on the 3D, how it's showing itself very clear. Here even it can be easy missed. Really, it can be easy missed, but look at the 3D, how it's shown this architectural distortion, and ultrasound correlate was not identified, has no ultrasound correlate, and biopsy revealed invasive ductal carcinoma grade 1. How many missing we have from the 2D mammography? Medina? We miss a lot, yeah?
Yes.
I'm missing, or if this is a invasive breast cancer, definitely in this complex parenchyma, we have a lot of missing.
Yes.
Do you agree?
Yes, agree. Totally agree.
Yes.
Mm.
Okay, this another patients. If you look for the 2D, it looks normal. Just scattered fibrotic parenchyma. But the 3D demonstrate an area of architectural distortion. Okay, and
very subtle. Very subtle.
Very subtle. Ultrasound was normal. And biopsy revealed invasive ductal carcinoma with carcinoma in situ. Okay.
Yes.
معلش ترى ممكن تحددي على الاريا في ال 2 دي في الميديولاترال والكرينيوكودال دي اصلا معهم مش دي كان ميست اصلا مش
2D views are normal. I said normal. I said it doesn't show itself on, we described that up to 47.5% 3D tomosynthesis can show architectural distortion occult on 2D mammography. This is one of the examples. I brought for you one case, demonstrate architectural area of architectural distortion picked by the tomosynthesis could not be seen on the 2D, or it was occult on 2D. See, that is why nowadays they combined for screening the 3D along with the 2D. And because of the radiations, they start to discuss about the synthetic 2D mammography. From 3D, they are doing 2D, okay? Post-processing, instead of expose the patient twice, 2D and 3D, okay? But at the same moment, they are studying the drawback of these, the advantages and disadvantages in screening mammography. Okay? Another case, this demonstrates also, this is 45-year-old woman. If you look here, it was normal. On the 2D image, no abnormality could be detected. At least at these locations. might be retrospective. We might say this area vaguely كده, with something there, might be something there, very subtle. But without seeing the abnormality on the 3D, definitely it will be passed as normal. And here they report it as normal. But on tomosynthesis, demonstrates and subtle area of architectural distortions, and ultrasound demonstrate here very subtle area. Okay, and the biopsy result, it was a radial scar. So by imaging, we cannot differentiate between malignant and benign architectural distortion. Okay, this is, we can see, you see, subtle area of architectural distortion in MLO, and this is spot magnifications showing some tethering and retractions in the contour and some speculated lines. And I think this is a different view. It looks like straight, lateral. You see?
Radiating
Seen in
side.
the MLO, and here more, yani, the difference in the view, it looks probably this is a 90-degree lateral ML view, demonstrate more distortion. But I don't see the CC view. Most likely it is a single view distortions, not seen in the other standard view. So what should be the next? It will be ultrasound. If ultrasound doesn't show abnormality, what should be the next? They have no facility of tomosynthesis. So
Follow up.
Biopsy.
okay. If they have other facilities like
MRI.
before MRI, yes. Okay. This yes, the area of retraction speculations seen في MLO single view, not seen in the other view. The finding suspicious on the spot, okay, and but was not seen in the CC view. No abnormalities in the CC view or ultrasound, okay, and this is, yes, this is a true lateral view, demonstrate the abnormality, which is also suspicious. I cannot say leave it like this. Since it is suspicious, I will proceed. See, do the MRI, definitely demonstrate linear enhancement, and diagnosis was biopsy diagnosis was high-grade CIS. We cannot ignore it.
Yes.
Okay, so but usually MRI is being reserved for only challenging, yani problematic cases. See, yani resolved by, not resolved by diagnostic mammography or ultrasound. And we have to keep in our mind that MRI does not have sufficient high negative predictive value. If it is normal, it doesn't mean that. It doesn't mean. So we have to ignore this. We can go back and take a biopsy stereotactic based on this MLO, or at least closely follow the patients. We cannot avoid, just say since MRI is normal, just avoid that means this is not a suspicious abnormality. No, still we have to consider it as a suspicious findings. Okay. Again, just let us go back to our approach. Distortion, look, confirm that this is established, it is a real abnormality representing architectural distortion. Look for the associated features, look for the aesthetic classification, and then localize the lesion within the breast. Okay, what about this case? What about this? What is these structures? What is this? What does it mean?
Surgical clips.
Yes, so she has previous intervention. Okay, the patient has previous intervention. And what about this circle? Demonstrate what?
Focal area of architectural distortion.
Yes, there is a focal area of architectural distortion. How you are going to manage this patient? He has previous intervention. So,
I think to do an ultrasound first, and then
why you will do ultrasound?
To see if there is an area of a suspicious area as residual mass, or after taking history.
History, I told you she has previous intervention.
Like surgery, or have a previous mass, and do surgery. If she do surgery, then you have to do ultrasound to see if there is any recurrence, or no, MRI to see if there is recurrence or residual. If the patient have
this long time, long years before, many years before.
For biopsy.
No. And this is normal after many years. After many years, you see this picture. It's called something.
Okay. So, any other suggestion? Do you agree always to her? Are going to ignore this patient and to say this is normal because she has previous intervention?
I'm going to do a biopsy for her.
Suhair?
Biopsy.
Still Suhair is talking?
No. I'm not
talking.
I'm not. Not me. I'm confirm it as normal after years. Someone say biopsy.
Who said biopsy?
Me, Medina.
Why biopsy, Medina?
Because this is a true architectural distortion. Maybe another different entity from the previous one.
Why is it different from the previous?
Because it's very far away from the area of.
Excellent. This is what I'm waiting to say. I am waiting for you to tell me this is far away from the site of previous intervention. So I have to consider it as a new lesions. This is not the area of intervention to say this is a scarring. This is far away from the area of intervention. I have to proceed. And this is the ultrasound. Demonstrate shadowing lesions.
Yes.
What is the difference between the two ultrasound, between this and this?
Here in the left side, the acoustic shadowing is more. Maybe harmony is added to the right one.
We said harmonic usually make it more conspicuous, but the one the technique that eliminate the shadowing is the compound technique. So this is because of the compound technique that eliminate the compound imaging, eliminate the shadowing. And you see, if it's a small lesions, it's difficult to be visualized. Here we could see the lesions by the shadow. The lesions are not very clear, but shadowing signifies that there is underlying lesions.
Yes.
And biopsy of this case revealed mixed invasive ductal and lobular cancer.
Shit.
Okay.
Yes.
So post-procedure changes, yes, it can be seen within the first 6 months after biopsy, as distortions and all these with the skin thickening and a lot of issue. An architectural distortion present on up to 80% of mammography at 6 months post-excisional biopsy, decreasing then by times to 35% at 2 years and so forth. Okay. 50-year-old asymptomatic for baseline study after left breast biopsy, which was negative for malignancy. Can you see any abnormality in this mammography? Can you show me who's gonna take it? Any volunteer? Can you see an abnormality?
Very dense breast.
Yes, extremely dense breast.
Yes.
No any, we are talking about architectural distortion. No
Yes.
any subtle area of architectural distortion here. Right or left?
At the left breast. There is
Who
an
said
area of-
left? Excellent.
So here at the upper outer quadrant of the left breast, there is an area of architectural
Excellent.
distortion
Anterior or posterior?
as the focal area of
You're
contour
right.
deformity. Contour
Excellent,
deformity.
excellent, excellent, excellent. Well done. Yes, yes. That is the area of distortions.
Yes.
See?
Yes.
Here,
Yes.
this is the area of architectural distortion. And this is a spot magnification view. So,
Spot magnification view show an lucent area with radiating lines from this area causing tethering of the parenchyma and focal area of contour deformity caused by tethering
okay,
of the
okay. So confirm the architectural distortion. Confirm the architectural distortion. So, okay. So, asymptomatic baseline after left breast biopsy, which was negative for malignancy. That is what is the questions you would like to ask? I did not see radiobake clips to make sure this is a site of biopsy. But there is a skin, if you look here, there is a skin changes, and I have to ask exactly where the site of previous biopsy. That was the site. That was the site of previous biopsy. So, how you are going to manage the case? Now, this is a site. This is a location of the previous biopsy.
The time of biopsy. What was it done? When?
Maybe many months before. This is the baseline. Few months.
Maybe post-procedural changes.
So,
You have to do an ultrasound.
okay, show the same area of
Follow up.
architectural distortion, doesn't add anymore. So you are going to code it as Barat 2, 3, or 4. Which one? And why? Huh? It's important. How we are going to manage this case? So here you start. You will give Barat.
For me, Birat 3.
Why?
To see, this is a baseline, to see if there is any change.
Excellent, well done. 100% correct. Because this is a baseline, and you have change, then you are going to follow. It will be Barat 3. Agree with you totally. This is Barat 3 for short-term follow-up. Okay, without clinical history, without clinical, the differential diagnosis it will be if you have no history of post-intervention. So you will code it as
Birat 4.
for biopsy. And differential would be
Radial scar.
or why you are going to biopsy?
Malignancy.
It can be still malignancy, it can be invasive cancer. It can be invasive cancer or radial scar. So you are going to do biopsy. Okay. Can you look for any things here? This is both biopsy, or this is both interventional scar. Look for the scar. Sometimes give different shape in different views. Look here and there. You see the shape a little bit different in different projections. Okay. So in the absence of appropriate history of trauma or surgery, then architectural distortion is suspicious for malignancy, and the differential diagnosis will be radial scar, complex sclerosing lesion. So we have to take tissue to do tissue diagnosis. Tissue diagnosis is highly recommended. In that case, because we have a history of previous biopsy, that is why we give the patient close follow-up or close surveillance. But if no trauma, no surgery, you confirm the findings, abnormal findings in the mammography representing architectural distortion, you have to report it as Barat 4 to get malignancy, to do a tissue biopsy and to exclude malignancy. Okay. So what are the etiology of the architectural distortion? What are the causes of the architectural distortion on mammography? What do you know about the causes of architectural distortion? How we can divide it? Hint.
We can broadly divide it into benign causes and malignant causes.
Or, you are right, or
procedure, for example, post-procedure causes. The benign causes are either
yes,
benign
or yes, you are right. Benign or malignant, or post-procedure, as we call it what? Secondaries, and then we have primary causes. Okay, so what are the primary causes? Primary causes
like sclerosing adenosis, like fibromatosis,
Why you start by rare things?
Radial scar. And secondary causes like fat necrosis, like post-surgical scars, like post-biopsy.
Okay, okay. So we have secondary etiology. This when there is a known previous intervention on the breast. We call it secondary cause. Post-scar, post-surgical scar, which is the most common, or post-biopsy, post-trauma, post-infection. If the patient has previous abscess healed by scar formations, all these we call it secondary etiologies. He has previous trauma to the breast. Either this trauma is biopsy or surgery, or trauma, yani accidental trauma, or healing infections. This is secondary. While primary, including both benign and malignant causes. The primary include all the benign and malignant causes, invasive cancer, whatever. Okay, when we go for benign and malignant, what are the malignant causes?
Like invasive ductal carcinoma and invasive lobular carcinoma, and rarely ductal carcinoma in situ.
Excellent. Okay, the invasive cancer, either the commonest invasive ductal, and then invasive lobular or mixed ductal and lobular. These are the more common. Uncommon is the DCIS. Okay, uncommonly presenting with this appearance of architectural distortion. What about the benign causes?
Like the radial scar.
Excellent.
Like, sclerotic actinosis. And rare benign causes fibromatosis. And,
any volunteers? What about the other benign causes?
Complex sclerosing lesions.
Okay, complex sclerosing lesion is same as
Sclerosing adenosis.
no.
Radial scar.
Yes. What is the difference between radial scar and complex sclerosing adenosis?
Not sure, but
when the lesion is 1 centimeter or less, is a radial scar. If it is greater than 1 centimeter, is a complex sclerosing lesion. Pathology, same. Radiology, same. Okay? The complex sclerosing lesion also can be called as radial sclerosing lesion because it is actually the same as radial scar pathology, but the size, only the difference between the two is a size. Less than 1 centimeter and more than 1 centimeter. It's okay? Like, and you mentioned the radial scar complex sclerosing lesion. That is why it should be like this. Radial scar / complex sclerosing lesion. Then sclerosing adenosis. Then
fibromatosis.
Fibromatosis at the bottom of the list because it's extremely rare. What is the percentage of fibromatosis? Okay. What is the percentage? The occurrence, the incidence in the breast, the fibromatosis? What is the incidence? Also, we call it as what? The fibromatosis. What is the common location of fibromatosis? Okay, We'll go for that. What about the other etiologies, benign etiologies? Do you remember? We said radial scar complexes, sclerosing lesions, and what? Sclerosing adenosis. Okay. Fibromatosis. What else? Huh? Fat necrosis, common granular cell tumor. Excellent. Granular cell tumor, one of the rare with fibromatosis at the bottom of the list. There are more common than these. Fat necrosis is more common than these. Abscess is more common. Hematoma is more common. Fat necrosis, hematoma, and abscess, and sclerosing fibroadenoma and sclerosing papilloma more common than these. Okay, so this is a list. Radial scar complex sclerosing lesion, sclerosing adenosis, both surgical, both intervention. We mentioned fat necrosis, hematoma, abscess, benign tumor, fibrosis or sclerosed fibroadenoma or papilloma, and rare speculated benign lesions like granular cell tumors and fibromatosis. So okay, these are the etiology or the diagnosis, okay, or the causes of the breast architectural distortion. So when you are looking for architectural distortion, you will put on your mind this list as an etiology. Okay. Again, we'll go back to the approach to confirm that or to establish this is the real abnormality representing architectural distortion, looking for the associations and then its locations. This is an example. This is my neighbor. I remember the case. This is my neighbor. She had pain. Sudanese lady. What about the distortion here? Then definitely we are talking about distortion. What else? The approach. Distortion. Where? And what is there any associated classification? Is there any associated features? That is it. That is it. Just tell me there is architectural distortion in by locations, and what are the associations? This is the whole approach.
Is it in the upper lateral?
Yes. Upper outer left breast. Okay. Architectural distortion associated with
Nipple retraction.
nipple retraction. That is it. Before nipple retraction, if you look for the medial breast and look for the lateral breast, look for the inferior and look for the upper breast. Her breast is almost fatty. It's fatty. That means what I have seen here, this is an abnormality.
Yes.
So associated with
asymmetry.
Yes, excellent. Yes, there are multiple focal asymmetries occupying the whole area or giving global asymmetry or global asymmetry due to multiple nodularity. You can describe it any area. And increase, even if you look here, the vascularity, obviously, there is increased vascularity along with distortion and band like going toward the nipple with nipple retractions. So what is next? It will be ultrasound. Yes. Ultrasound, it was inconclusive findings. Then
if we have MRI, we can do MRI.
Yes,
Yes.
MRI done just to see the disease extent. But they had taken biopsy from ultrasound guidance. See, look for the MRI, the lesions seen as segmental clump enhancement and following the area of multinodular asymmetries on the bias. Okay. Another example. Quickly. Go ahead.
There is an area of architectural distortion at the center of the breast, behind the nipple with associated nipple retraction and
Before nipple retraction, there is no any other associations.
and associated lymph node enlargement, lymphadenopathy, intramammary.
At the same area of distortion, is the density same as the rest of the breast?
No, with increased high density, most likely, I will do a spot compression view
Before,
to see if there
how
is.
you can call this high density? Is it focal or diffuse? The area of high density. It is not a clear mass. It is not a clear mass, yeah?
Yes, it could be a focal asymmetry.
So we call it as, it is a focal area. It is not occupying the whole. It is occupying a focal region and high density area. So I will call it as, describe it before, so here. The focal added density. We call it as?
Focal asymmetry.
Yes, it is associated with focal asymmetry.
Focal asymmetry.
There is area of distortion associated with focal asymmetry and nipple retractions or subtle increase, skin thickening, periareolar skin thickening. There is also there is intramammary lymph nodes. Okay.
Yes.
The upper outer. I don't know exactly its status, but I cannot read it more than that. It's okay. So what is next?
The next step to do an ultrasound.
Okay, before ultrasound. And you do?
A spot magnification view.
Okay, this is the spot. Does it add anything for you?
This is confirmed and the architectural distortion with radiating straight lines. I don't see any mass or speculated mass.
You don't see mass? Ultrasound, the speculated, confirm this is an speculated mass with adjacent architectural distortion. This is a mass. What is the definition of a mass?
The mass has a 3 volume.
Okay, and has a convex, partial or complete convex border. There is no convex border here.
There is partial convex border at the upper part.
Yeah, we said, yeah, this is all this convex border.
Yes.
See? And even here there is convex, but these are distortion going on. So this is a mass. So the spot magnification demonstrates a mass with architectural distortion, and it was a lobular carcinoma. This is my patient. It was a lobular carcinoma. Okay. And what about this? Any volunteer? Yalla, let us go quickly.
Irregular,
There is
architecture, yes. There is architecture distortion in the retroareolar area.
This is
The
retroareolar.
right breast.
It is retroareolar or where?
Deep.
It's deeper. It's the center.
It is central. It is mid-central, in the middle depth. Okay.
Yes. With associated focal asymmetry.
Excellent. Associated asymmetry. And
Skin thickening.
band-like, okay, extending to the nipple with subtle nipple retraction on MLO. Look, and the skin thickening. Look for the nipple here.
Axillary lymphadenopathy.
Yeah, and there are lymph nodes are relatively suspicious, lacking the hilum. This demonstrates the hilum, while the other are lacking, and this even demonstrate minimal perinodal edema. Okay, just limited evaluation might be, it need to be visualized by ultrasound to confirm that demonstrate more suspicious features. But here, at least this globular rather than oval is getting more globular, and there is subtle area of lesion, perinodal edema, I mean, raising the suspicious for metastatic node to be clarified and characterized further by ultrasound. Okay, so next. And even there are faint calcification here, if I could see it well. Faint, so it will be next.
We could do a spot magnification, compression view.
Okay, this is a spot.
The spot view shows that confirm the architectural distortion.
Only architectural distortion?
No. There is a speculated mass.
There is a mass, yes. There is an irregular mass with extensive architectural distortions, yes. Okay, this is ultrasound. See, look, see the mass.
The ultrasound shows mass with irregular margins with posterior shadowing. A complex mass.
Posterior shadowing or enhancement?
Posterior enhancement.
Heterogeneous. And this is the band like going toward the nipple. Look for the band and look for the nipple. See, the nipple would seem to be involved or infiltrated. This is a heterogeneous mass. It looks as if it is multiple masses. I don't remember exactly. Might be the same mass from the different angles. Let us see. This is the MRI. Okay. This is the index lesions. Okay. It seems to be here. Because the mammography is because the breast is mobile, sometimes the lesion is moving 1 or 2 hours or even 3 hours. Okay. When compressing the mammography from the exact origin of that lesions. But if you look for the ultrasound, the lesion, it seemed to be not the midline, not exactly central. Look for the cursor, and even here on MRI, a little bit off midlines. And look for the edema, and look for the segmental ductectasia, okay, and the surrounding edema on T2. Okay. Another case. Who's gonna take it? No volunteer?
This is craniocaudal and medilateral oblique view of the left breast, showing speculated mass with associated architectural distortion at the upper outer quadrant.
Where is the speculated mass? Can you see
At-
the speculated mass in the standard view here? Is it, it has a consistent, having a consistent shape from in the two views?
No, in focal asymmetry in the craniocaudal
Focal?
view.
This is focal. It's taken
No,
almost a quadrant.
Quadrant. This is yes,
Large area. So this is
global asymmetry with associated.
yeah, there is
architectural
global
distortion.
asymmetry with distortions, or there is architectural distortion associated with global asymmetry. And
trabecular thickening and skin thickening with associated nipple
edema,
retraction.
yes, there is diffuse parenchymal
and the skin edema.
Skin edema,
with nipple retraction.
Aywa, there is band-like density extending from the mass or from the global asymmetry here, or the going from the index lesion going toward the outer. If you see it here again, and with associated thickening and retractions.
Yes.
So this architectural distortion with global asymmetry. So as we describe, we identify or establish the distortion, look for the associated feature, associated classifications, and then the locations. Okay. So here, two different cases, 1 and 2, the architectural distortion associated with
microcalcifications.
What?
With microcalcification.
And we spent how many hours in describing the classifications?
The name of the classification. This is pleomorphic.
Yeah. How come?
Okay. Pleomorphic. Pleomorphic classification, and it is grouped and segmental global. Just the name, the distribution, the morphology is pleomorphic, and
both case 1 and case 2.
I'm talking about 2.
You are talking about 2?
Yes.
Okay.
So the morphology is pleomorphic, and distribution.
Only pleomorphic. Only pleomorphic.
Pleomorphic and coarse heterogeneous.
Look for this.
Sorry, this is linear. Linear branch. Linear.
Yes, okay, it can be linear. Okay, pleomorphic and linear type of classification. Because of the limitations, I cannot. It might be regional. It might be segmental. But at least not alas, it doesn't matter. Regardless of distribution and regardless of the associations, it is BIRAD. If just I have these classifications without anything, it will be BIRAD.
4C.
4C. Regardless of distributions, 4C. And associated with this significant asymmetric architectural distortion, it will be upgraded to 5. Full stop. Okay?
Okay.
So the other one, there is distortion, asymmetry, and pleomorphic calcification. Sorry, not very clear, but it's pleomorphic, segmental, because it is coming from here, pointing toward the nipple. Yeah. Okay.
So it is 5. Okay.
Okay. So both cases were invasive ductal carcinoma. Those are my patients. were invasive ductal carcinoma. This is from the literature. So you have you have architectural distortion with
pleomorphic regional micro calcification.
With pleomorphic calcification and asymmetry. What about these densities? There is asymmetry and calcifications. Okay? And they mentioned that it was a radial scar. Or biopsy revealed radial scar. So how you are going to put your report? You'll put it by RAD2?
No, because the radial scar has the tendency to become malignant.
It has tendency to become malignant. Are you sure, hint? Or in different way? The remark today is not available, huh? We miss her. She don't know about the lecture or what? Strange, she is not available.
Or I mean, it can be associated with.
Yes. So we call it what? We call it those type. We call those type of the lesion as what?
Collision.
Huh?
Recurrence.
Collision.
Like what? What other group, including in this radial scar and others? What other lesions group with radial scar we call as? Anybody knows? Borderline breast disease or borderline lesions? Why they call it like this? Why they call it a borderline? Hello? Hello? Anybody knows, or let me tell you? Huh? Hello?
Tell them, yeah.
Okay. They call it borderline because not completely malignant, but are concerning. And usually excision is recommended because after excision, they might be upgraded and associated with underlying malignancy. Okay? By themselves are not a malignant lesions, but considered to be risk borderline, sometimes associated with underlying malignancy. And for the radial scar, if I remember, it's up to 25% associated with underlying invasive cancer. And I think especially the tubular one, tubular carcinoma, if I remember. But those, what are other lesions included in this group of borderline breast disease or borderline lesions? If you remember, we describe in the introductory lectures.
Atypical ductal hyperplasia.
الو
الو
ايوه
ايوه
ما
بس
فجأة النت قطع ورجع فوقفنا وين؟
وقفنا
ألو؟
border line
another borderline
breast disease.
lesion.
اتكلمت كلام كتير كله ما سمعتوه.
ما سمعنا يا دكتور، وقفنا هنا.
فصل النت سبحان الله ورجع تاني. قلت لكم انه these are borderline lesions, are concerning lesions, are not per se malignant, but are concerning because are associated with underlying malignancy. Okay? And generally, after core biopsy and reveal this borderline lesion, in general, they are recommending excision biopsy. Okay, excision of the lesions to look for any underlying malignant lesions or upgrading of that lesions. And I told you we discussed that in the introductory lectures. We'll say we are going to discuss it more. And inshallah, in benign breast diseases, we are going to give more details about this. But at least now, you can understand there are group of lesions included in the borderline breast disease or borderline lesion. Anybody knows the rest of this group include what?
Atypical ductal hyperplasia and atypical lobular hyperplasia.
Excellent, excellent, well done. What else? The complex sclerosing lesion radial scar, as we mentioned, and sclerosing adenosis, and something called columnar alteration with prominent atypical, something like that. See? I don't remember exactly. But these are the lesions you see when seen in the core biopsy. Usually they recommend excisions, but I understand that, or I know from one of the expert breast radiologists, when they are doing vacuum assisted, when after the vacuum assisted biopsy being incorporated in the breast interventions, and because the radial scar is small and completely being removed by vacuum assisted, they are not recommending excision after that. See? And in this case, after, hello? It was invasive lobular carcinoma. Hello?
أيوة يا
معاي
دكتورة
انتوا؟
نور. أيوة
معاك
نعم.
يا دكتورة،
سامعينك.
سامعين. أيوة.
Okay. This lesion after excision, the biopsy, excision and biopsy, the lesion upgraded to invasive lobular carcinoma. Okay. Can you see any architectural distortion on this mammography? I think this is an architectural distortion. Okay. Seen right CC view demonstrate architectural distortion. So, and even associated calcifications, distortion with foci of calcification. Okay, what is the architectural distortion? What is the essential facts related to distortions and calcifications? Hint.
The positive predictive value does not differs from that of architectural distortion alone.
Okay, so the calcifications is not going to affect a lot the positive predictive value of architectural distortion. The one with and without calcification, more or less same. What else? or did not give significant difference in the rate of malignancy. What else? Presence of calcification is going to support in the visualizations of the lesions in the images to get biopsied, yeah?
Yes.
Especially if it is subtle, the architectural distortion is subtle but associated with calcification is going to help in the aid, okay, together in targeting the for biopsy or stereotactic by stereotactic techniques. Okay. And about this is my patients. So this is an let us go a little bit quick.
Speculated mass.
Excellent, well done.
Associated with yes. Associated with the skin retraction.
Yes, it's causing distortion because it is the desmoplastic reaction or the spicule extend to the adjacent skin with thickening, retraction, and dimpling of the skin, so resulting in some area of distortion. So this is BIRAT
5.
This is BIRAT 5. Okay, retraction and puckering of the skin associated with mass, locally advanced cancer. It's okay. It is a local advanced cancer because it is infiltrating into the adjacent skin. Architectural distortion can be seen as an associated features. We discuss the architectural distortion as standalone or architectural distortion associated with calcification or asymmetry. When architectural distortion seen with the mass, then we will consider it as a secondary features. We'll not consider it as a primary features. Definitely the primary features will be the mass. For instance, if there is the mass that causes architectural distortion, the likelihood of malignancy is greater than in the case of a mass without distortion, definitely. See, if you have a mass, irregular mass or whatever, but if it is associated with distortion, definitely the probability of malignancy will be high and the grading definitely. That is why the speculated mass is BIRAT 5, not like the microlobulated mass and the other indistinct mass. You remember that when we consider the systemic evaluation of the mass. It's okay. So the two most common type of invasive cancer presenting as architectural distortion, we said the invasive ductal, lobular, or mixed. Okay, and the common is the invasive ductal, representing up to 90%, and the lobular is the remaining. And the irregular mass or calcification, most common mammographic findings of invasive cancer, architectural distortion, we said, is generally considered the third most common, frequent, sometimes the only presenting features of breast cancer. A retrospective study, pure invasive lobular carcinoma, speculated mass or architectural distortion were the most common radiographic findings, and clinically, the patient can be entirely asymptomatic but present with palpable lump, but can be present with a palpable lump or anatomic distortion of the breast on physical examination, and so forth. Okay, let us see these examples. Intraductal carcinoma in 62-year-old lady presented with a palpable mass. Look for this palpable, okay? This is the area of palpable abnormality. Look how it is distorted with global asymmetry, and here associated with pleomorphic calcifications, microcalcifications. See, the microcalcification definitely is better appreciated on spot magnifications, and look for the ultrasound demonstrate indistinct, irregular, heterogeneous hypoechoic mass with posterior shadowing, and the guided biopsy revealed invasive ductal carcinoma. Okay. This is the examples of DCIS. Seen here is an area of architectural distortions. Okay, and here this is clump ductal enhancement on MRI, and MRI guided biopsy revealed DCIS. The patient had a history of surgical excision marked by the scar marker. You see, this is a scar marker, I think. So this is the area nearby. It's not exactly at the same location, nearby. I have to go further and evaluate it well. And it was, it representing my, I think, okay. This is the area, that is the area of, this is the area of, okay, mammogram, contrast, MRI, area of clump. What about the mediolateral? Mediolateral oblique, enhanced subtractions, area of distortions type. It's okay. Anterior to the area of distortion, arrow. This is the area, the arrow is the area of distortion, and this is the surgical, yes. So this is the area of surgical is a little bit, not exactly at the same location as the markers or the area of distortion. And it was an area of ductal carcinoma in situ. Okay. These are interesting. Look at this. This is my patients. The previous one, it was from the literature, but this is my patients. Can you see it? Quickly, let us go quickly.
This is craniocaudal mammogram of the left breast showing focal asymmetry at the center of the breast with associated architectural distortion and microcalcification representing pleomorphic calcification and skin thickening and nipple retraction.
Only that? The skin di mala.
There is an abnormality. I think it is an artifact. This area of
What about this? Why it is like this? Why it's coming like this? Coming here, coming here, coming here, Would you like to ask any question?
Is a patient have do surgery before this image?
Excellent, well done. You have to ask about, yes, this is post surgery.
Yes.
This is both therapy, both cancer, breast cancer therapy, treatment, surgery and radiation therapy.
Okay. So this distortion, you have to do an ultrasound to see if the MRI to see if there is recurrence or residual or
before going for
cancer.
that, before going for
spot magnification view.
Okay, okay. What else? Do you remember our approach? We said,
and
just
another
to evaluate,
view.
for evaluate architectural distortion, we have to have history. When
yes,
and you ask about history, excellent. We have to have. We have to do diagnostic. This is diagnostic. It's okay. This is also already diagnostic. What
yes.
else? What else? What
Another
is
view.
important? Another views. Okay, demonstrate the same. Type remaining.
I think you have to do another imaging to see if there is recurrence or residual.
Previous images.
Well done. For post-operative, always ask about previous. Make sure this is the baseline or previous. Because if you remember that patient, when you said it is a baseline, I will give it by rat 3 to follow it up.
Yes.
Okay, because it was a baseline study. But if there is previous, your management, it might be different. So you have to ask about any previous images.
Yes.
Okay. About history, she was 48-year-old lady, had history of breast conservation treatment for infiltrative ductal carcinoma, came for annual follow-up. What is abnormality and what is the diagnosis? You describe the abnormality. Can you give a diagnosis now? Okay, she asked about the previous. The next step is to look if this is a baseline or previous. This is the other image.
It's showing a large area of asymmetry with associated skin thickening and trabecular thickening, nipple retraction, and calcification. This is the same like. I think the previous show the large area of.
Which one is the previous? Which one is the previous?
At the left side. At the left one is the previous image.
I might show you the previous. You have to ask me. Which one is the current? Which one is the previous?
The previous on the left side. On the left one is the previous.
I did not say the previous on the left, but it's okay. Yes, here by this arrow, yes, the left one is the previous and the right one is the current one. You have to ask. The examiner might raise for you the earlier one first.
Yes.
Okay, make sure which one is the first, which one is the second. No problem. This is the earliest.
بس عشان شفت هنا الحتة كانت large يعني very large في in the previous one والنيب retraction ذاته كان associated يعني نيب retraction advanced with the current one.
You cannot say advanced. You cannot say advanced because of positioning. Here nipple in profile and there is retraction, but the nipple here is within the breast. It's difficult to tell, but there is some irregularity around twitch and wrinkling of the areolar skin due to retractions of the post-operative. But you can consider the dense area of asymmetry. This area of asymmetry now definitely is getting less size and intensity.
Yes.
So how you are going to manage your patients?
You have to follow up the patient.
Okay, so most likely, and if you look here, the calcifications is more.
Okay.
This is the vascular calcification. but the pleomorphic calcification is getting more than the previous one, and a little bit more distortion, though the asymmetry is regressing. So,
Upgrade it.
are you sure there is no underlying residual or recurrence?
You have to do a spot compression view to see if there is an underlying mass.
Okay, there was no spot compression view.
I have to do MRI.
أنا خدت في رأي برضه ال MRI بنجيب اللي نمشي عليه.
MRI, jumping to MRI before doing ultrasound?
Because the MRI is a benefit on post-operative patient.
But if you look here, this density is getting smaller, less dense. Even if you look for the center, is more lucent. Yes, there are associated architectural distortion, but the area is getting more lucent than before even. And this is evolving calcification. Pleomorphic calcifications might represent what? Okay, let me go for ultrasound. This is ultrasound. These two studies of ultrasound, what do you suspect? Which one is early and which one is recurrent?
The left one is representing an early ultrasound.
Excellent.
Because
yes,
the mass
this is the earlier on the left and the current on the right. So
representing the residual mass confirmed on ultrasound.
the residual mass. Why the residual mass is regressing? Malignant mass is getting
Chronic
small.
hematoma or seroma.
Huh?
It's a chronic hematoma or seroma. Hematoma
Hematoma. Okay.
or seroma.
Yes. Okay. Hematoma or seroma. Right. Okay. And the calcifications. And why there is more speculations. And even look here, look for the adjacent area on ultrasound. This is the seroma. It's getting small, but what about this area, hyperechoic and this hypoechoic? And on mammography, you have calcifications. How you can explain all these changes?
Surgery on fibrous tissue is liable to be.
There is distortion here. There are some distortions. Look for the distortions. Distortion and increased echogenicity. Okay, yes, the seroma cavity or the central part is getting less, but getting heterogeneous, and even look here within, getting thick wall. The wall is getting thicker. And there is surrounding distortion and altered, mainly hyperechoic, and on mammography corresponding to hypodensity, speculations, distortions, and evolving pleomorphic calcifications. How you can explain this scenario in post-operative? So representing
Scarring.
Scarring. Why is scarring causing these changes? What can cause speculations mimic the malignancy, but it is benign? Benign mimicker of malignancy at the site of post-surgery.
Necrosis of the previous tumor.
Why the previous tumor is regressing?
Responding to the treatment, either radiation or chemotherapy.
This one is immediate. This is post chemotherapy, post radiation, and this is the follow up. So this is the baseline post treatment.
Inflammatory mastitis, post radiation mastitis.
But what is that? What is exactly is inflammation? But what is the inflammation giving you? Lucency on mammography and hyperechogenicity on ultrasound, and giving calcification simulating cancer, and this it will growing. The calcification will grow by time, huh?
Is it fat necrosis?
Yeah, it is a fat necrosis. It's a typical fat necrosis. That is a typical fat necrosis. Okay. Oh. So this case was no recurrence, just we are going to follow the case to see the next follow-up. But it was not, from the appearance, it was not suspicious, you see? It was going with a fat necrosis and no need to go for MRI. Just were, yeah, I remember, just we followed the patients for that one. Okay, huh? Well, this is also my patients. So it's obviously from this cyst-like appearance of the skin, it will be
surgery.
Post-surgery. It's obviously post-lumpectomy. So how you are going to manage? What does it show? This is the skin thickening, more thickening here, and these distortion, area of distortion and asymmetry here. Huh? What is next? Was a baseline. I don't remember she has previous. So we are going to do
ultrasound.
This is ultrasound.
It shows
This is ultrasound.
Shows the mass-like.
Mass-like, okay, indistinct, surrounding larger area of distortion at the site of scarring, okay?
Cutting sign.
So extending toward the reactions going toward the skin. But if I look here within the area of asymmetry, the central area is much more lucent, okay? But I cannot guarantee in this case because it was a baseline and I'm not sure, unless to be correlated with what? With pathology. If margin are free, we are going to follow, and this is typical fat necrosis. We are going just to follow the patients. If there is any suspicious or margin very close, or there is anything, then we can proceed for MRI to confirm or to do biopsy. But this is also a case of fat necrosis, very typical case of fat necrosis, okay? And this is from literature, the typical case of a fat necrosis. Look how it simulates malignancy, is speculated mass, but the center is fatty. See, the central region is a fatty. This is confirmed case of fat necrosis. This patient having a fat necrosis. Like, okay, what about this case? Looks like
Post-surgical also.
or surgical. So how we are going to manage? Now you understand. Huh?
To see the previous image, previous mammogram.
There is architecture distortion, is skin thickening. Diagnosis, we cannot. Next step is look for if there is other images. Okay, this is the previous images. So
more more skin retraction or
only retraction, more. What are the new findings in?
Skin thickening also.
More skin thickening and retraction is okay. What else?
The density decreased.
Which density? The orientation is different. I think this is CC and this MLO. And look for this is the area of architectural distortion. Why it is not very clear now? Because the overall the pre-parenchyma is edematous and distorted. Look for the Cooper ligament thickening, not like previous. This is only the site of lumpectomy and the skin scarring. But now there is diffuse parenchymal as well as skin edema. So something new.
Yes.
It will be your diagnosis. Can you say this is only fat necrosis and full stop?
No.
No. So it will be suspicious. This is suspicious findings, and that case she had a recurrence. She had recurrent cancer. See? So we'll go further, we'll go ultrasound, and we might do if we could find anything to be biopsied. Otherwise, we will proceed for MRI in this case. Okay? This 2 different time X-ray. Mammography for the same patient. Can exclude recurrence?
No.
Yalla, let us go quickly. Why you cannot exclude recurrence?
There is also increase in skin thickening and edema. There is
but might be the first one and the other is second one. You did not ask. You have to ask which one is the first, which one is a follow-up.
Yes.
You are going to tell I cannot exclude recurrence. I want to know which one is the first one and which one is the follow-up.
Yes.
Okay. So now.
Yes, decrease in the.
Yeah. No, now the density is decreasing and these things. Okay. If you find, Yani, if you find these stitches are displaced, its density is not much, but these stitches are being displaced far away from each other in spite of the diffuse thickening decrease, okay, but this, there is spacing of these sutures.
Yes.
What does
Yes.
it mean?
It means recurrence of the mass.
Yeah, it means there is underlying mass effect.
Yes.
Diamide, something growing. I have to take it seriously. Not necessarily. This is post-radiation changes. Okay, it will regress by time, and still this lesion, growing lesion, not enough to cause much edematous changes and all this. So I have to take all features together, not only look for the edema of the breast and edema of the skin resolve. That means everything is resolved. I have to look at the area of asymmetry at the scar sites and to analyze. And if I have a calcifications, if the patient develop coarse calcification at the site, I have one case I will show it to you later. And how we are going to analyze the follow-up case regarding the calcifications. If it is coarse calcifications, okay, you have a large calcifications in that area.
With fat necrosis.
Going with fat necrosis, okay. Now you have a ball of calcifications due to the fat necrosis at the site of operations, and you have a follow-up. How you are going to look at that calcifications as a predictor for recurrence?
According to the type of calcification itself, is it suspicious or benign type of
I told you, you have a large ball of coarse calcifications.
Large ball, you mean rim, or what do you mean?
Dystrophic calcifications. Large piece of dystrophic calcification, dense large peak of dystrophic calcification, ball of dystrophic calcification at the site of surgery, like that, or surgical scar. So how you are going to use it to manage the patient, to make sure to use it as a predictor? Like now, we set these surgical clips. I have to consider it. I am looking for the asymmetry at site of scarring. If the density is increasing, it will be alarming. If the size is increasing, it will be alarming. If there is spacing of the sutures, it will be alarming. So there is a mass effect is going on. Regarding the calcifications, also, I'm going to look, is the calcification being displaced? It will be the same. There is something pushing that calcification, or if it's getting fragmented. So there is something is eating, infiltrating. You see? If the calcification coarse dystrophic type of calcification, large dystrophic and getting fragmented, that means there is underlying lesions resulting fragmentations, and this is indirect signs for recurrence. You got the point now, okay?
Yes.
This is a patient's, okay? This is the current, and this is the prior image. Can you see any difference between the two?
Displacement of the calcification. The space between the calcification is widened.
I can see the
And
density,
there is added density.
Yeah, there is area of asymmetries. And I feel that the density is getting more in the current. So I need to clarify this area. There is not very clear. In the CCV, not clear. So this extended lateral, because the stitches are here and most of the stitches are posterior, not shown. So I had done, or they had done, extended lateral view, and by doing extended lateral view, the arrow demonstrate here a focal asymmetry, which is new, not seen in the previous study. So at the site of lumpectomy, this it will be signs of recurrence. This is a spot magnification, confirm the focal asymmetry on ultrasound seen as indistinct suspicious heterogeneous hypoechoic mass, small mass. So this is one view, asymmetry obscured on the other view, and it was a recurrent cancer. Okay, so this is post-surgical. Can be, we have a lot of benign post-surgical features can be mistaken for cancer and can simulate, okay, cancers. We have to be aware about it. What about the post-surgical complications? Do you expect? You have seroma, hematoma, infections, abscess formations, and then you have scarring and fat necrosis, recurrence. This is a scenario. Any increase in size of the distorted area, okay, it will be suspicious. And we have to proceed for ultrasound and sometimes for MRI. Look for this. It seemed to be like a mass, but it was only post-surgical changes and scarring, simulating the mass. And this is another example, okay, of a post-operative scarring, okay, or post-operative changes simulating cancers. And this is a case, obviously, here it is suspicious as area of distortions, and look for the ultrasound also. But when I'm looking for this spot magnification, it seems to be dystrophic calcifications, okay, an area of lucency. So is going more toward fat necrosis. However, by this appearance, I have to take a biopsy. I'll not leave it like that. I'll take a biopsy and let us see. Okay, here there is architectural distortion microclassifications. Okay, and here the ultrasound revealed hypoechoic shadowing mass, heterogeneous, and this is a magnifications view at the site of lumpectomy showing classic fat necrosis, which is then as classified as all cysts, okay, on mammography. These are all cysts, okay, with thin rim of calcifications, but they had done ultrasound guided biopsy and confirmed the pathology of fat necrosis, okay. But sometimes we are doing a biopsy for, I have some couple of cases, I'll show it to you later. We proceed for biopsy to evaluate for a fat necrosis. As you know, one of the mimicker of breast cancer, and definitely it is an inflammatory, benign inflammatory process. Okay, this lady, this old lady, 70-year-old, she had here, this is a small nodule, a biopsy proven breast cancer. And this is, if you look here, this is area of asymmetry. Look here and how it changed its shape. And as I told you, post-surgical scarring usually for different view, giving much difference in shapes, okay? And adjacent to the surgical clips here noted, but this is the post-operative changes. I need volunteer other than hint to tell me what is this, what are these arrow point to, and why this shape looking like that. And what else features that yani, might give clue about this case, helping us to show the case.
Assalamu alaikum.
Walaikum assalam.
These arrows may point to thickened ligaments of Cooper. Also, I can see bilateral skin thickening and some areas of focal asymmetry at both breasts also. At the right axilla, there may be benign looking lymph nodes, oval in shape and
Who's
okay.
talking? Who's talking?
أنا ولا
ولا ازيك ولا اهلا بيكي شرفتينا تماما اليوم.
أنا اللي تشرفت بكم.
يلا you are welcome.
Okay, at the inferior aspect of right breast, there is area of architectural distortion by the shortest arrow. Okay, I will ask about the history of this patient.
What is the history you'd like to
Is
ask
she
about?
symptomatic or
No, she has no symptoms.
is there any edema or generalized body edema?
No,
She's asymptomatic.
she's asymptomatic.
Okay, skin thickening is bilateral and thickened Cooper ligaments are bilateral. But the small area of architectural distortion is unilateral, so for me it's suspicious. Next step is correlation with ultrasound.
Okay, good. Good management. Another suggestion, you are right. طيب. Which area you are talking about in for architectural distortion on the right?
The area with the area pointed with the shortest arrow.
You mean
Inferiorly.
here?
Yes, here. Yeah.
Here, this one?
Yes.
Huh? And
أيوة.
what about this? What about this one?
The skin thickening with calcification.
Thickening
Yes,
without
calcified. Without calcification. Okay, focal areas.
maybe okay, we accept, no problem. We can accept some calcification, not clearly seen, but the added density might reflect some calcification is there. I could not appreciate it well, but it might be. So why the skin here? It looks like an irregular skin, both sides. It's not a smooth skin. Look for the skin here. Straight and smooth. Look for the skin here. Yes, mildly.
Yes, there's
but
a symmetrical
smooth.
technique.
But here, look for the skin. It looks like wavy, bilateral wavy, huh? Why?
Is it a dermal disease? Some sort of skin disease?
Skin disease.
Does she have any
Okay,
skin
no.
disease? Scar or something?
She has no skin. She has no skin. She has no skin disease.
No previous surgery?
Excellent, well done. Now you start to think about surgery. What about which type of surgery you would like to ask about?
It is a bilateral surgery, so it may be plastic surgery like breast reduction or something like this.
Excellent, well done. Excellent, well done. Good approach. Yes, plastic surgery, breast reductions. And this, you see, is swirling architectural distortion characteristic of bilateral mammoplasty. The other things is the bilaterality. How come the distortion, both lower breast are seen in the lower breast from the nipple? This is skin thickening going down and irregular due to scarring. Scar is usually from the nipple inferiorly, and look for the nipple not are pointing up, not like the normal You see,
Yes.
the breast is lifted up. You see, these are the clue for the bilateral mammoplasty. But this is a case of mammoplasty. You see, medilateral oblique showing architectural distortion, producing characteristic swirling patterns. Okay, in a patient 52-year-old underwent bilateral reduction mammoplasty 4 years ago, and it demonstrates skin thickening and retraction at lower breast, and the swirling pattern, architectural distortion. This is a characteristic for the scar of mammoplasty. Excellent, well done, Wala, well done. Okay,
Shukran, thank you.
and you might find the complication of surgery like hematoma, seroma, abscesses, and so forth, fat necrosis. I have patients who many patients with this mammoplasty develop fat necrosis, you see. Huh? What about this lady? This is my patient also, 60-year-old lady, have chronic mastalgia or chronic breast pain. About to finish, ya shabab. Quickly, let us finish. نمتوا؟ الو؟ سهير؟
أيوة معك.
عبير؟ ها؟ What about this case? Did you see an abnormality?
This is craniocaudal view of the right breast, showing global asymmetry at the lateral part of the breast with associated architectural distortion. And
where is architectural distortion?
At the lateral part of the breast.
If I told you this is a parenchyma, but there is architectural distortion, where exactly the area of architectural distortion?
At the retroareolar area.
Yes, there is focal area of architectural distortion just behind the nipple.
Yes, with associated retroareolar skin thickening and nipple retraction.
Yes, yes, you're right. What else?
With diffuse edema, breast edema.
No breast edema, no.
This is from
nothing else, nothing else. There are calcifications, there is calcifications.
Yes.
Okay, this is ductal calcifications. There is ductal calcifications. Okay. So, what do you think?
This is suspicious area. You have to do an ultrasound.
Okay, ultrasound doesn't show mass. Demonstrate some ducts distorted, mildly dilated ductectasia. Okay, with some thickening of the walls and beaded appearance, and some echogenic areas going toward the skin and areolar skin ampullate.
It might be presenting inflammatory process.
Excellent, well done. Like, yes.
Like TB.
If it is not a TB, which one is more common? The most common. Which one is most common?
يعني especially for the elderly. Any volunteer? And this is ductal calcifications. This يعني not very clear, but it is ductal calcification. What does it signify, these ductal calcifications? Is it benign or malignant ductal calcifications?
Rod-like.
Some as lucent center, some faint and small rod-like.
Plasma cell mastitis.
It is plasma cell mastitis. So how you can explain that area of architectural distortion? Is part of chronic. What are the components of the plasma cell mastitis? What is the pathophysiology?
Inflammation within the ducts and
plasma
cell
and the periductal. This is a periductal mastitis. The periductal mastitis, you see. Okay, this calcification, the architectural distortion is due. Look here, these all are periductal mastitis. Secretory mastitis, periductal inflammations. Okay. What did you see here?
This is craniocaudal view of the left breast, showing an area of architectural distortion at the medial part of the breast with associated pleomorphic calcification.
Yalla, you said at the medial part. Medial, then you have to tell anterior, middle, or posterior.
Middle part of the breast.
Okay, it seemed to be toward the posterior.
Posterior,
mid to posterior, yes. I accept it. Posterior, yes. So
now is associated pleomorphic microcalcification.
If I told you this is screening and this is incidental findings.
You have to do a diagnostic mammography.
Yes.
And to see both craniocaudal, mediolateral, oblique view, and to do a spot magnification view.
Okay, it seems the same. Same findings. So, this is your differential diagnosis. You have to go for
ultrasound.
Okay, negative.
This is represent BIRAT 4. You have to do biopsy.
You have to do biopsy. Excellent, well done. Yes. And it turned out to be borderline. What do you expect?
Fat necrosis if the patient has a previous intervention.
No, not fast necrosis.
Radial scar.
Radial scar, it is not very big. Okay. Can be radial scar or if I told you ultrasound demonstrate area of parenchymal alteration, hypoechoic with shadowing with microcyst changes. So you will go for by these descriptions, you will go for what could it be a hint?
Sclerosing adenosis.
Sclerosing adenosis. By the description is sclerosing adenosis. Okay. Okay. This is my patient, 51-year-old, having on hormonal replacement therapy. So, can you see the speculated radiographic findings on this mammography? Where exactly?
I can see it posteriorly at the center.
Do you mean this?
Yes.
No, this is part of the parenchyma.
Okay. Okay. The most dense area at
Excellent. Where?
at the middle.
Yes.
At the middle.
Middle outer ولا middle you mean mid third? When we talk about the middle third, يعني this is the anterior, this is the middle, and this is the posterior third. You are talking about the middle third of the breast in the depths?
Yes, in the depth, in the middle third.
In the middle third. So, okay, outer or medial or central?
Central.
This is excellent. Well done. You mean this?
Yes.
Excellent. It is. This is a speculated, or this is a focal area of architectural distortion speculations. There is central lucency. You will see it here. If you look, these are associated with asymmetry and this is specules, but the central area is relatively low dense. And this is the lesion on ultrasound. So what is next?
Biopsy.
Biopsy. What do you expect? This is non-palpable. Incidental findings.
Either with stereotactic biopsy or ultrasound guidance.
But can be done by ultrasound and was done. He had biopsy. But what do you expect the etiology? The pathology tend to be what? From the list we had mentioned before regarding the etiology for architectural distortions. What do you expect to be benign or malignant?
Malignant from the ultrasound features and mammographic features.
Okay, so you are going to suspect invasive ductal or invasive lobular or mixed or DCIS. Okay.
Okay.
You are not considering the benign findings at all. Huh?
It can be benign.
Like what? Like what? You're right.
Okay.
Like what?
It doesn't look like fat necrosis.
Yeah.
Radial scar.
Excellent. And this it was a radial scar. After excision, it was a radial scar only, not upgraded. Okay. This is another example from that was my case. This is my case, but this is from the literature, another case of radial scar. Okay, histology shows radial scar. And this is another case, see here, of architectural distortion and with long spicules, proven to be just a benign radial scar. And here, this is a radial scar. Can you see the lesions? Where? This is the previous, and this is the current. So, focal area of architectural distortion and in the long spicule seen on interval. Where exactly in this dense breast, extremely dense breast? Right or left?
Right.
Voila.
Right.
Excellent.
Right at the right breast.
Excellent.
In the central retroareolar area.
Well done. Excellent.
Central
yes.
anterior.
Yes. It's exactly that is the regions. This is the regions, you see, and this is the lesions here. You see, this is the lesions, and it was a radial scar also. And this is another radial scars, look like a mass. It is seen an indistinct, hyperdense mass on the mammography and irregular hypoechoic mass on ultrasound. So can simulate malignancy, but typically it's usually seen like this. See, this is radial scar. Okay, and look here, there is bilateral MLO. Okay, the patient show focal area of architectural distortions and microcalcification in the upper outer breast here, or in the upper breast seen, and subtle distortion seen here on ultrasound. What do you suspect? The patient had pain. She complained of pain. What do you expect? The pathology. Sometimes she might have pain or have mild palpable abnormality. So this is the cases of sclerosing adenosis lesions. And look for this ugly shape of sclerosing adenosis lesions. You cannot differentiate it from malignancy, definitely. And even the core biopsy tend to be benign, you are going to recommend biopsy. And it was sclerosing adenosis lesions, okay? What about this? Yalla, let us proceed. Few cases remain. Hint?
أيوة. There is an area of architectural distortion associated with asymmetry involving the left breast central area with retraction, some retraction of the skin, retioalveolar skin, and on ultrasound, it seems that it's taking the يعني شكلها زي الضغط.
You're right. Why you are hesitant? Yeah.
Yes.
Yes, it is a duct. But it is a simple duct.
No, mass within a duct.
Yeah, soft tissue mass, lobulate soft tissue mass within a duct and associated with
architectural distortion.
So what do you expect? Just put in your mind the etiology. We described it before.
Which etiology?
What are the soft tissue within the duct?
Either papilloma or intraductal carcinoma.
Okay. So why it is associated with distortion?
Invasions. It started to invade.
Could it be a papilloma?
Sorry? Papilloma?
Could it be a papilloma? Or could the papilloma, or does the papilloma associated by architectural distortion?
Usually this occurs with intraductal carcinoma when it becomes infiltrating.
Does it look like invasion? Okay, does the papilloma cause architectural distortion? Question in another way. Does papilloma can cause or do papilloma or can papilloma cause architectural distortion?
Yes.
Who said yes? Who said yes? Be confident, don't be hesitant.
Me. Medina.
Medina, لا اسقط الله لك حسا.
Allah يخليك.
Like what? Why papilloma can cause distortion? If you remember, in the etiology, I've mentioned that before saying granular cell and fibromatosis, there is one more common benign tumor associated with these fibrotic changes and architectural distortion, like sclerosing or hyalinized fibroadenoma and papilloma.
Yes.
Same as what will happen with fibroadenoma can also occur with papilloma. This is rare entity can result in architectural distortion, sclerosing papilloma. Okay, but this is case. This benign tumor related to duct and it was sclerosing papilloma. Okay, and what about this, Medina?
This is also tubular linear asymmetry extending from the medial side of the left breast to the nipple with nipple retraction and involvement of the nipple. Surrounding skin thickening also. In the ultrasound, there is a linear soft tissue mass.
Not one. This is one, this is one.
Oh,
Okay,
multiple.
this is area.
Yes.
Yeah, multiple. Multiple interconnecting.
Yes,
Multiple interconnecting.
Yes. Intraductal masses or ductal masses.
Why you said ductal masses, intraductal masses?
Because they are distributed.
This is one, this is one, and this is the direction of this is different. Okay, and this is not all are directed toward the nipple. Overlapped. Interconnecting.
Yes.
So what could it be? Long standing.
Long standing.
Associated with discharge. Post discharge.
Post discharge. From the mammography, involvement of the breast of the nipple. It looks like any non-benign or malignant process.
And the history?
The history of chronicity.
Long standing, post discharge.
Long standing and post discharge looks like chronic
Yes,
inflammatory.
from the skin, the skin. The post discharge is from the skin, from the areolar skin, not from the ducts, not from the papilla. So it's going with
Sclerosing papilloma.
Why is sclerosing papilloma? Why the sclerosing papilloma presenting by discharging pus? You have distortion, you have Van-Dyke densities with adjacent skin thickening and pus discharge.
It's like fidget disease of the nipple.
What?
Fidget disease of the nipple?
No, not budget, no. What is budget disease? Next session, I'm going to ask you about budget disease of the nipple.
Okay. Inshallah.
So, what if it is not in the breast? If it is in other parts of the body, what could it be? Something, okay, irregular hypoechoic with posterior enhancement, and we have having tract. If you look here, this is a tract, okay, from the lesion, from one of the lesion going toward the areolar skin. This is a nipple, and this is the areolar skin laterally. If you look here, this is the nipple, and this is the areolar skin. For the areolar skin, this is the tract coming and tethering and causing retraction, okay, buckering retractions by pulling and adjacent thickening. So what is tracking toward the nipple, long standing and with pus discharge?
Could it be fistula?
Yes, fistula. Or tract going toward, yeah, cutaneous fistula toward. In a case of
Chronic abscess.
Excellent. Chronic abscess. Who is talking?
معاوية دبورة.
أهلا دكتور، ازيك؟ أنا اتفقت أسألك، كنت في البيشنت بتاعت الماموبلاستي بس ما كنت عارفك موجود. Did you attend with us?
في النص كده يعني جونا ضيوف كده وطلعت
لأنه I check for that case. I check your name. You was not there. There was a case of mammoplasty done by Dr. Wala, يعني excellently described and doing the case. Okay. Yes, this is chronic. Chronic. You said what? Chronic what?
Chronic abscess.
That is chronic abscesses. Yes, these are chronic abscesses with discharge. And if I remember well, in that case it was. What do you expect to be?
Idiopathic granulomatous mastitis.
One of the differential idiopathic. And if it is not idiopathic, yeah, you are right. But usually, yani, idiopathic doesn't give discharge, yani giving some ulcerations. Yeah, it can, but rarely complicating giving all these things. But as you agree with me, is not common. Okay, yes, but it can be specific. It can be specific granulomatous mastitis, like specific granulomatous mastitis. TB, yes. Yeah, if I remember that case, it was a tuberculosis. It was chronic infections, likely. But the history, what I mean, Medina, the descriptions and history, and you have to take the all constellations of finding to get your diagnosis. Okay.
Okay.
So here we have these indistinct lesions, same on MRI here, and enhancement in a 30 2-year-old lady in a case of fibromatosis, left breast fibromatosis. This is the fibromatosis. If I ask you to ask me one question regarding this lady, what would you like to ask? Yes, she has rare fibromatosis. What does fibromatosis associated with in the breast? Associated with what? Yes, it itself is rare and the association is rare. But the association is, what would you like to ask me about? Does the patient has what? Even for you, Dr. Muawiyah, you have done the plastic surgery.
Yeah.
Those who have
Other lesion in the other part of the body.
Like where?
Family history. Family history.
Yes. You are right. Other part where exactly? The commonest is the commonest location for that.
The back or face.
Abdominal wall.
Yeah.
The abdominal wall is the commonest locations of desmoid tumor.
Yes, desmoid. Yes.
Yeah. This is extra abdominal desmoid. The breast fibromatosis is extra abdominal desmoid tumor. Yeah, it represents only 4% of the extra abdominal, but within the breast tumors, it represents 0.2% only. It's extremely rare, but it has a rare associations with implant, silicone implant. It occurs with a silicone implant. Rarely, it occurs with a silicone implant. Okay. So rare, the fibromatosis is rare along with the granular cell tumor, is infiltrating mass composed of fibroblast, fibromyoblast, and collagen within the breast parenchyma. It's rare, 0.2% occur in the breast, locally aggressive benign tumor, unknown etiology, high rate of recurrence, you see, and characteristically, it's simulating breast cancer in all images, but characteristically having low T2 on MRI, okay? And this is a case of architectural distortion on mammography and ultrasound due to granular cell tumors, which is also extremely rare, originating within primitive nerve cells. It has variable or various appearing. Can be ill-defined or speculated mass or architectural distortion. At the same moment, can be a circumscribed mass. Usually without microclassification, no association microclassification. On ultrasound is the same. Okay, so at the end, the differential diagnosis, just as to remind you, differential diagnosis for architectural distortion, the commonest benign cause are radial scar, complex sclerosing lesion. These are the commonest. Then sclerosing adenosis, fat necrosis, post-surgical. These are the commonest benign, and with a radial scar is usually satellite lesions with central lucency and long spicules. Okay, and with sclerosing adenosis, characteristically associated with microclassifications, it can present as a mass with distortion or distortions, or focal architectural distortion as standalone lesions. Fat necrosis, usually associated with inflammatory reaction is skin thickening and tethering and retractions, and you might see microcalcification or dystrophic calcifications. Post-surgical scarring, yes, it might be associated with the skin scarring, and the parenchymal scarring, it will show different shape with different views. And specifically for the mammoplasty, we said it has the characteristic swirling pattern in the inferior aspect of the breast. Okay? Centrally, skin having a wavy appearance, and the nipple are pointing or are lifted up. So you will see bilateral nipple lifted and pointing up, and it might be associated with the complications like seroma, abscess, or fat necrosis. And the commonest is the fat necrosis. I have seen a lot of patients of mammoplasty having a fat necrosis. See? And the malignant causes, we said, invasive cancer is the commonest. With the commonest of these, invasive ductal carcinoma, followed by invasive lobular or mixed type. And the ductal carcinoma in situ uncommonly presenting with architectural distortion maximum up to 10%. As you know, DCIS are presenting with microcalcifications. The common presentation. The architectural distortion is not a common presentation for the DCIS. Usually it is microcalcifications. Might be associated with architectural distortion. Okay. So take home message, architectural distortion, the non-mass but potentially ominous clinical features observed in many breasts and cannot be used, mammography or mammographic features cannot be used to differentiate benign from malignant causes of architectural distortion. Causes simulating very closely breast cancer and fat necrosis, and at the same moment, the cancer might simulate radial scar and so forth. The positive predictive value of architectural distortion for cancer ranging between 60 to 74.5%, and architectural distortion is less likely to represent malignancy when it is detecting on screening mammography rather than that detecting on diagnostic mammography, as well as architectural distortion without sonographic correlate. If it has sonographic correlate, definitely the probability of being malignant will be more. Architectural distortion with calcification or asymmetry and without do not have a lot of significant difference in the rates of malignancy. It is suggested that early detection of architectural distortion may be associated with more significant improvement in prognosis of early detection of breast cancer than in prognosis of breast cancer than early detection of calcifications. And architectural distortion represent the most commonly missed abnormality in false negative cases and can be very subtle early features of breast cancer. Due to its high positive predictive value for cancer, architectural distortion should not fit the criteria for observations unless the case is suspected fat necrosis or suspected post-surgical scarring. Don't say, and you prove that this is an architectural distortion, you should not say the case for observations. Go for biopsy. How to manage and what is the algorithm to manage the architectural distortion detecting on 2 or 3D like that. If you prove this is real abnormality, this is an architectural distortion on 2D mammography, then you have to, okay, if you have facility of doing 3D, you can do to prove it. Okay, do the tomosynthesis. If you haven't, directly proceed for ultrasound. And if you have done, you have do the 3D, the tomosynthesis, and you could appreciate the and you prove the architectural distortion. Also proceed for ultrasound. Why? And if you could detect the lesions at the site of the abnormality sonographically, you can use it as guidance for biopsy. Okay, if you could not see the lesion on ultrasound, then go back for mammography. And if you have facility of stereotactic, you can use it to take a biopsy. Otherwise, you can proceed for MRI. Okay, and if there is MRI correlate, it can be used as a guidance for biopsy. If not having facility for that, and the lesion not seen on ultrasound, or the lesion not seen on ultrasound and not seen on MRI, then and the stereotactic biopsy cannot be performed, the remaining it will be the tomosynthesis. If there is facility for tomosynthesis guidance, localization, needle localizations, we have to use it, okay, to guide the surgeon to remove the lesions. If not, then we have to closely monitor the lesions with a short-term follow-up. Okay, if architectural distortion seen is only seen on tomosynthesis, not on 2D, also we have to proceed for ultrasound. These occur when they are using tomosynthesis in adjunct to 2D mammography for screening purposes or in screening setting. You might see architectural distortion in 3D not seen on 2D. See, and as we mentioned before, we have up to 47% of architectural distortion detected on tomosynthesis, while being occult on the conventional 2D mammography. So the occult 2D architectural distortion seen in 3D should not omit the biopsy. We have to proceed. So the probability of malignancy less than the lesion present on 2D. If we have architectural distortion seen on 2D, that means this is a real architectural distortion. This is more suspicious architectural distortion that have seen on, also seen on 2D. But if we could appreciate it in 3D, which is expected to pick even subtle findings, it's still a probability of being malignancy not small. It's up to 45.2%. It is a good percentage, is enough not to omit the biopsy. We have to proceed to biopsy using the imaging, okay, the imaging at which we could see the abnormality, and the imaging having the capability to be used as a guidance for biopsy. This is the algorithm to manage architectural distortion. And what about these lesions? It is just to refresh at the end. Architectural distortion.
Speculated mass.
Excellent. This BIRAT
5.
Yes, this is speculated mass BIRAT 5. And thank you very much for attention.
Thank you for you.